Hello. So I would like Dr. Deeb.
Good afternoon.
Good afternoon. I would like to present our next speaker to the audience, Dr. Deeb. He is a neurologist who works in private practice in Dubai. He is going to talk to us today about MS prodromes, and this lecture is sponsored by Sanofi. Dr. Deeb, the virtual floor is yours.
If you can just 30 seconds to upload the presentation, it'll be live in 30 seconds.
Okay, we just need a couple seconds for the presentation. So with that, how are you today, Dr. Deeb?
All ready for this talk. If you hear shouting in the background, it's my son shouting his head off at the PlayStation. I don't know what good it does to shout your head off at a computer, but hey, that's what he does.
We've all done that, but we did it on Ataris and Nintendos back in the day.
Yeah.
So there we go. Your presentation is loaded, and we're ready to go. Thank you.
So I would like to thank Dr. Ahmed Shatila and the organizers for asking me to present this talk today. I was asked to speak about multiple sclerosis, the prodrome. I've seen from the schedule that everybody has heard a bit about multiple sclerosis, and I think that's good to have an idea about the condition before we talk about the so-called prodrome. As Dr. Ahmed said, this talk is sponsored by Sanofi, who are the makers of teriflunomide, which is Aubagio, which is a treatment for multiple sclerosis. They also have a second product on the market, which is alemtuzumab, which is Lemtrada. I'd like to start with a patient presentation. So, of course, when we think of multiple sclerosis, it's women, 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 but we have to remember that men also are affected by multiple sclerosis. So this is a 38-year-old man who first presented to me at the age of 33 in May of 2015. He presented with a 1-week history of right arm sensory disturbance. Now, I understand most of the audience are internists and general practitioners, and therefore this is important because these patients often present initially to internists and GPs and family practitioners. And right arm sensory disturbance could be anything from a peripheral nerve entrapment, such as carpal tunnel syndrome or an ulnar neuropathy. It could be a pinched nerve in the neck, cervical radiculopathy, but of course it could be other things in the brain as well, including tumors and strokes and multiple sclerosis and so forth. So we need to ask the right questions. And we need to do the neurological examination rather than just giving vitamin B complex and sending the patient for physiotherapy and seeing what happens. So if we see a patient like this, often the neurological examination is normal. And in this patient, the neurological examination was normal, except for some sensory abnormalities in the right arm that did not follow any specific nerve root distribution. And therefore, this brought to my mind the thought that maybe we're dealing with something at the neck or in the brain, and I went on to ask other questions. And indeed, for the past 1 year, the patient had had a history of intermittent mild urinary urgency. He would feel the need to go, and he would need to go real quick. It was mild. He didn't really seek medical attention for it, but it was something that he did note. With this history in mind, I of course thought of the brain and the cervical spine, and I ordered for him an MRI, and that was in the same month, of the brain and cervical spine. The MRI study revealed multiple non-enhancing white matter lesions, plaques if you like, and in the cervical spine there was a single non-enhancing lesion at the level of C3, C4. If we look at this MRI from 2015, you can see a small spot over here. You can see some haziness around here and here as well. You can see it much more clearly in the next cut with many periventricular lesions and further down as well. Having seen this MRI, the first thing that came to my mind, of course, is multiple sclerosis, central nervous system demyelination. So we stuck a needle into this guy's back. A lumbar puncture is a very useful investigation. A lot of people may be apprehensive about it. Once I find that most of my patients, the majority, I don't want to say all, but the majority, after the lumbar puncture is done, when I ask them, how was it compared to what you thought? They all agree that they were a bit anxious about it, way more than they should have. So this guy underwent cerebrospinal fluid examination, which revealed the evidence of 7 oligoclonal bands. Oligoclonal bands are specific proteins that are made in the cerebrospinal fluid and indicate inflammation within the central nervous system. They are not specific to multiple sclerosis, but they are present in up to 95% of patients with multiple sclerosis. So if you don't see oligoclonal bands, think again about the diagnosis. It still may be possible that the patient has multiple sclerosis, but you want to make sure you're not missing anything else. So May is when he presented. By then he's had his MRI, his lumbar puncture, and in June 2015, he was given the diagnosis of multiple sclerosis, and he was started on disease-modifying therapy consisting of teriflunomide, which is Aubagio. So what is teriflunomide or Aubagio? We have resting and slowly dividing lymphocytes. And when these slowly dividing lymphocytes divide, the B cells and the T cells, they go through 2 different pathways. Do not ask me the name of this enzyme. Every time I read it, I forget it within a few minutes. And through another pathway, the pyrimidine salvage pathway. When you have activated lymphocytes, so lymphocytes that have been activated by an external stimulus, an immune reaction, you've got further proliferation. And this enzyme helps with the RNA and DNA synthesis, so you have many more T cells and B cells. Introduction of teriflunomide or Aubagio blocks this enzyme, dihydro something or another, blocks this enzyme and reduces the proliferation of rapidly dividing cells. So it acts selectively and reversibly to decrease proliferation of the autoreactive T and B lymphocytes and largely preserving the immune function and other immune pathways. So this patient presented in May 2015. 1.5 years down the line, in December 2016, we did another MRI. He had had no symptoms. We do routine MRIs yearly, more or less, as long as there are no symptoms, for the first 5 years, that is. And there was a single non-enhancing new lesion at the level of C1 with no change in the plaque that was previously noted at the cervical spine at the level of 3 and 4. And in the brain, there was actually no change and perhaps even some improvement. And the patient was thus maintained on teriflunomide. Some people may consider the occurrence of a single plaque at the level of C1 a failure of therapy. But in of itself, a single lesion without clinical relapses and without further progression, for many, is not enough to warrant a change in therapy. For some who consider themselves more aggressive in the treatment of multiple sclerosis, this would warrant a change in therapy. I chose to leave the patient on teriflunomide. That was in December 2016. He did quite well with no relapses as such. However, in April 2018, he developed an episode of right-sided trigeminal neuralgia. And we know that patients with multiple sclerosis are at higher risk of developing trigeminal neuralgia. In between April 2018 and September of this year, he had on and off bouts of pain, sometimes bearable, sometimes unbearable. For example, in May 2019, requiring a course of Neurontin for treatment. He did reasonably well. However, he does have residual numbness in the thumb and index finger in the right arm, which has persisted until now. So he had incomplete recovery from his initial episode of multiple sclerosis. He still has intermittent urinary urgency, which is very mild. It has not progressed, and it does not really stop him from doing anything he needs to do. So this is his residual disability 5 years down the line. Remember, he presented in 2015, and now we are at the end of 2020. He had had one relapse, stable symptoms, though with a bit of an incomplete recovery, and a breakthrough of trigeminal neuralgia. He's been maintained on teriflunomide. He's had no clinical relapses, as I just said, and he's been having yearly MRIs, which is my practice for patients with stable MS, is that yearly MRIs, if there's something happening, we do it more frequently. If we look at his most recent MRI studies, this was his MRI back in 2016, I believe I showed you earlier. And this is a corresponding scan. This is a better quality scan. You can see that he still has some white matter lesions, but they're not as fluffy and big and evident as they were back in 2016. And if we look at another cut, this is 2020, this is 2016. Again, you can see the size of the periventricular white matter hyperintensity is less intense over here. This lesion was there before. This was more prominent before, it is less prominent. So overall, we can say that in the brain, there has been no progression, and if anything, perhaps some improvement. In the cervical spine, there was that one additional small spot at C1, which did not progress over the years. This leads me to talking about the multiple sclerosis prodrome, which was a new idea to me when I attended the ACTRIMS 2020 webinar. It's a yearly congress. It's the European and the North American research and study group for multiple sclerosis. There are yearly, what do we call these? We don't attend these things anymore. Conferences, yes, that's what they are. There are yearly conferences that take place either in Europe or the US, and every 3 years it's combined between the two. And in this conference, there were several talks, specifically by Dr. Helen Tremlett, who introduced the idea of the multiple sclerosis prodrome. And I think this is very relevant to primary care physicians because they see these patients way before we ever see them. The idea of the MS prodrome is not strange. We do have a Parkinson's disease prodrome, and I'm sure sometime during these 3 days, maybe you already did or you will hear a talk about Parkinson's disease. There's a very well recognized Parkinson's disease prodrome. People with Parkinson's disease for many, many years before onset of the illness may exhibit REM sleep behavior disorder. You know that during REM sleep, our muscles are deactivated or paralyzed in a sense, so we're really motionless except for the rapid eye movements. In these patients, the muscle inhibition does not take place, and these people act out their dreams. So they may be kicking their spouse in the bed during sleep and having wild movements and vocalizations as well. So REM sleep behavior disorder is a big risk factor for Parkinson's disease. Depression may be, autonomic dysfunction and olfactory dysfunction, somnolence, slight motor signs, and certain imaging abnormalities. Constipation may also be a prodrome for Parkinson's disease. We know that now talk has started about Parkinson's disease starting in the gut, that the dopaminergic abnormalities start in the gut, and the patient may present with many, many years of constipation, and that would be an ascending type of Parkinsonian disorder where it starts in the gut and it affects the brain in the later stages as opposed to starting in the brain. So there is good evidence now for prodromal Parkinson's disease, and I think by the end of this talk, I may be able to convince you that there is good evidence for an MS prodrome as well. So is there an MS prodrome that we can measure via healthcare use? There's a Canadian study published in 2017 in which healthcare use was higher in the 5 years before a first demyelinating event or multiple sclerosis symptom onset. This included hospitalizations, physician visits, and prescriptions filled at an outpatient pharmacy. There were 78% higher rate of hospitalizations, 88% higher rates of physician service use, and 49% relative increase in prescription numbers, drug classes dispensed. Now the question is why? Why is it that patients that develop multiple sclerosis have increased healthcare utilization in the 5 years prior to the diagnosis? Well, more data, this is from 2018, tells us that 50% more physician or psychiatric visits in the 5 years pre-MS onset for any sort of mental disorder. There were fewer pregnancies in this cohort, but more treatments for hormonal preparations. Why is that? Well, perhaps women with unexplained symptoms may be avoiding or delaying pregnancy during the prodromal period. There were more visits during the preceding 5 years for complaints such as fibromyalgia and pain. We know that pain, the incidence of pain, is increased in multiple sclerosis. There were more visits for headaches and migraines. Not that headaches and migraines are directly related to multiple sclerosis, but there were more visits for such. There were more visits to urologists, and we can understand visits to urologists due to bladder disinhibition or urgency or urinary retention or so forth. There were more visits to dermatologists, and there has been some evidence to say that this may be related to an underlying autoimmune mechanisms, that some dermatological conditions are autoimmune in etiology, as is multiple sclerosis. And this was true more for the patients with relapsing remitting multiple sclerosis, which has a strong autoimmune disorder, inflammatory disorder, than the primary progressive forms of multiple sclerosis. There were also more visits for sleep disturbance and irritable bowel syndrome. Sleep disturbance is often a reflection of underlying anxiety, depression, or some comorbid psychiatric condition. Irritable bowel syndrome is often seen in patients with functional neurological disorders, and I was very happy to hear Dr. Giovanni address functional neurological disorders. They are extremely common, and how you deliver the diagnosis to the patient is extremely important. And treatment is, as stated earlier, cognitive behavioral therapy and other forms of interventions. If you type in functional neurological disorder and go to the Mayo Clinic site, I think it gives you a very, very good description of the condition, not just in functional movement disorders, but functional neurological disorders altogether. It's in the gray zone between neurology and psychiatry, and I think it gives you a good approach to start dealing with these patients.
Dr. Deeb?
Yes?
5 minutes remaining.
Well, I better rush then. What are the potential features of an MS prodrome? Well, in a UK GP study, there was evidence of prodrome up to 10 years before the diagnosis of MS or CIS. Insomnia, fatigue, anxiety, depression, pain, and GI, as well as urinary and anorectal issues. Now, some people said, could this be a bias? Could there be some bias in the way it looked at the literature? Well, in the same study, they looked at insect bites, and insect bites are, black and white. You can't really have a bias there. And it did not differ between active and control cases. They looked at Norwegian conscripts. So these are men only, and they were all studied. Lower cognitive performance was noted up to 2 years before a diagnosis of MS, up to 6 points lower on IQ. People with primary progressive MS did even worse. There was higher health and mental health service used by mothers of children diagnosed with MS in the 5 years prior to diagnosis of the MS. Could it be that the pediatric multiple sclerosis prodrome affects the mental health of family members? Or could it be that the maternal mental health, smoking and obesity, can be a marker or risk factor for pediatric MS? Another German study indicated that perhaps we were misdiagnosing MS, that perhaps when these patients came with skin sensation related complaints to our GPs, to our internists, perhaps even to our neurologists, and with mobility issues, these were brushed off as non-specific and a diagnosis was not made. That was also a possibility. There was also a strong association with a psychiatric prodrome, and this was not specific for multiple sclerosis, but it also applied to rheumatoid arthritis and inflammatory bowel disease. There were about a 1.6 incident rate ratio in the 5 years prior to diagnosis of psychiatric comorbidities. Now, is there evidence for axonal damage during the prodrome? Why is it important to identify it during the prodrome? Well, serum neurofilament light levels, which you will hear a lot about in the next few years, are a very important markers of axonal damage and for MS. And it seems that in a military study of mostly white men, these levels were elevated up to 6 years before MS onset compared to age, sex, and race-matched controls. The last few slides I would like to spend on the idea of the MS prodrome radiologically. And I'd like to introduce you to the idea of radiologically isolated syndrome. We'll skip the central vein sign. This applies more to neuroradiologists and neurologists. We are seeing a lot of this because everybody with a headache, everybody who bangs his head, everybody who loses consciousness ends up, well, many of them end up getting an MRI. And when you do these MRIs, we end up with these white spots on there. And then, the ball game starts. Is it or isn't it MS? So what is radiologically isolated syndrome? It's the presence of incidentally identified white matter abnormalities on the MRI. But these have specific criteria, and unfortunately, a lot of our general radiologists do not adhere to these criteria or are maybe not very well aware of them. That these lesions should be ovoid, well circumscribed and homogeneous foci with or without involvement of the corpus callosum. That there should be T2 hyperintensities measuring at least 3 millimeters, so not any little spot will count, and fulfilling certain criteria called the Barkhof criteria. And these should not be consistent with a vascular pattern. And there should be no history of clinical symptoms. If there's history of clinical symptoms, it may be multiple sclerosis, not a radiologically isolated syndrome, and various other conditions. So what are the Barkhof criteria? What are the criteria for these white spots? Well, for them to be, you have to have 3 out of 4 to call it radiologically isolated syndrome. So you have to have more than 92 spots, not just 2 or 3 spots here and there, or 1 gadolinium enhancing lesion. You can have 1 infratentorial or spinal cord lesion, more than 3 periventricular, which means they have to touch the ventricle, and justacortical, which means next to the cortex. You have to have 3 out of these 4. Why is it important to recognize radiologically isolated syndrome? 35% of these patients will convert to MS within 5 years. More than 50% will convert to MS within 10 years. There is even something called pre-radiologically isolated syndrome, and that's when you satisfy only 2 of the 4 Barkhof criteria. And there is high-risk radiologically isolated syndrome. That is when you have the radiologically isolated syndrome with oligoclonal bands in the CSF, or spinal cord infratentorial lesions, or gadolinium-enhancing lesions. These are more worrisome than the other radiologically isolated syndrome. I will not go through this, but one of our difficult questions is, how do we prognosticate? How can we tell if someone's going to have the so-called benign MS, which is a very old term, and a very minority of patients have this, and you can only diagnose it in retrospect 20 to 25 years down the line, or somebody's going to have aggressive MS. You basically need to look at all the features: sex, age of onset. Is it a motor presentation or an optic neuritis or a sensory presentation? Are there oligoclonal bands? Are there neurofilament light chains? Does the patient smoke? What's the vitamin D level? What's the relapse rate? Is there incomplete recovery? Is it unifocal or multifocal? Many factors go in there that give you a sense whether this is going to be a intense MS or a mild MS case. I hope this gives you a good overview of part of the MS prodrome, and I'm happy to take any questions if there are any.
Thank you, Dr. Deeb, for the interesting lecture. Definitely the MS prodrome is something I think with time we're going to get learning more and more information about it. So in regards to questions, I mean, you kind of alluded to it, but at the same time, so a lot of these patients who have MS, they may have symptoms years and even decades before their diagnosis with symptoms. But at the same time, there's already an increased utilization of MRIs done already for patients, sometimes for appropriate reasons or inappropriate. So how do you think this will play out in the future? Will we be doing more MRIs, or should we be looking at doing MRIs for people who come to the office a lot with non-specific symptoms? How would you approach this, or how would you advise our primary care colleagues?
You don't want me to answer this question, Dr. Ahmed. I think when it comes to healthcare, our health is most valuable. And I'm not willing to accept any ridiculous insurance company or financial constraint that's going to be placed upon the health and life of a patient. I suggest that the powers that be do something about the ridiculous price of MRIs in this city and in this country, yeah, before telling us when we should and should not do MRIs. That would be my impractical suggestion.
Okay, thank you. Is there a difference between multiple sclerosis and bilateral sclerosis.
Yeah. I have no idea what bilateral sclerosis is. There is amyotrophic lateral sclerosis, that's ALS, motor neuron disease. That is a disease of the peripheral motor nerves. That Lou Gehrig's disease, that's a completely different condition. Multiple sclerosis is central nervous system demyelination.
Exactly. That's kind of what I thought. I think the person who posed the question may have meant something else. How can we differentiate between functional cause or organic in MS, and between functional symptoms and real symptoms?
Yeah, well, all patients have various complaints, sometimes sensory numbness, tingling, dizziness, and so forth. And patients with MS also have that. To be considered as an MS relapse, symptoms have to last for at least 24 hours. At least that's by definition. Now, what happens when a patient with multiple sclerosis comes to us, and we've seen this very often, and they have symptoms for 2, 3, 4 hours and they go away? It's really difficult to know what to do with these symptoms. If they are self-limited, if they are short, we just leave them alone. But if they're prolonged, we scan, we see if there's any evidence of disease activity. We see if there is any enhancing lesions. We see if there's any change in the neurological examination. And if there is, that will, of course, make us believe that these are more true symptoms rather than functional symptoms. Of course, if there is an objective evidence of a deficit or a finding on neurological examination, then we would not think that these are functional symptoms. And please remember, functional symptoms are just as disturbing to the patient as real symptoms. So this distinction shouldn't be there. Dr. Giovanni tried to tell us how to explain a functional symptom as a glitch in the computer. There have actually been studies. There are studies on patients with functional neurological disorders where they do an MRI of their brain and they find activations in certain parts of the brain that you do not see in normal controls or in normal controls who are faking these symptoms. So medicine and neurology have not advanced enough for us to offer diagnostic tests for these patients, but there is something ongoing either in the electrical signaling in the brain or in the neurotransmitter signaling in the brain that's causing these symptoms. And cognitive behavioral therapy helps you take control over your brain so that you get control of over these symptoms and they don't propagate.
Got it. Thank you. And I mean, they've even done studies with people with non-epileptic seizures versus epileptic seizures. Even though one is more organic, one is non-organic, both groups will suffer the same type of injuries. So organic or non-organic, they're still placing themselves at an increased risk. So it's kind of real, but it's real for the patient. There is a question here. How will early diagnosis using prodromes change treatment? Would it necessarily change treatment, or would we just improve monitoring, I think?
I think we are just starting to learn about this, but I draw to your attention to Alzheimer's disease and Parkinson's disease. Yes. With Alzheimer's disease, changes are taking place in the brain 20 years before the first onset of symptoms. That's why all our treatments for Alzheimer's disease are failing. So we need to identify these conditions as early as possible so that we can start, or scientists can start looking at treatments as early as possible. If we wait too late, we may be missing the boat. We know that for sure for Alzheimer's disease. We know it as well with Parkinson's disease. You lose 90% of your dopaminergic cells before you get the first symptoms of Parkinson's. So with MS, we've seen in studies that early treatment, once a diagnosis for MS, is better than delayed treatment. So perhaps if we're able to identify a prodrome reliably, perhaps earlier intervention will be of benefit, but we don't know that for now.
Thank you very much, Dr. Deeb, for the very interesting lecture. Definitely learned a couple new things today. Thank you for coming and giving us this.
Thank you for asking me to be with you.
Much appreciated, and you have a good day.
You too. Bye-bye.